This recording is on drugs across a lifespan, drug interactions, and adverse reactions. And you can see here we've actually covered, we're actually going to cover the highlights of 6 chapters in the textbook. So a lot of the material found in this lecture is material that you've come across before, and what I hope to do in this lecture is to actually bring all the information together so that it's in a format that's easy to understand, and it's a format that's relatively simple. So the first thing we're going to talk about is we're going to talk about interactions between 2 or more drugs. So as you can see here, if you have interactions between 2 or more drugs, what happens is it can lead to increased effects, it can lead to decreased effects, or it can create what we call a unique response, which is a response that's not associated with any of the drugs when taken individually. So let's look at the increase or potentiative effects. So in terms of the increase effects, it can be an increase in the therapeutic effects or an increase in the adverse effects. So if we look at the increase in the therapeutic effects, what we have here is we have 2 antibiotics, and when they're given together, they actually increase the ability to actually destroy the bacteria in question. If we look at the potential for 2 drugs to actually lead to increased adverse effects, what we see here is we see aspirin and warfarin, and both drugs are involved in inhibiting the clotting pathway. And so what you have is if you give aspirin and warfarin together, the likelihood of hemorrhage or clots not forming is actually fairly high, because both of them work to actually inhibit the clotting cascade. The middle row is when you look at interactions between 2 or more drugs that have a decrease effects. So a decrease effect can be a decrease in therapeutic effects. And if we look at the 2 drugs here as an example, both of them work on the beta adrenergic receptors. But what happens is that metoprolol is an antagonist, so it reduces activation, whereas Ventolin is a beta agonist. So it promotes or enhances activation of the beta adrenergic receptors. And so it's like you actually stepping on the brake pedal as well as the accelerator pedal at the same time. You're not actually going to go very fast at all if you've got one foot on the brake, one foot on the accelerator. So it's that kind of analogy there. And then in terms of 2 drugs interacting to decrease adverse effects, what we have here is we have naloxone, which is a mu-opioid antagonist, and you have morphine, which is a mu-opioid agonist. Right? So again, we're looking at a decrease in the adverse effects, specifically a decrease in respiratory depression and the possibility of a person going into a coma and dying with an overdose of morphine. What's often given is naloxone, which actually cuts across the effects of morphine because it's a mu-opioid antagonist. The third category, creation of a unique response. Example here is disulfiram, which when a person actually takes it on it by itself, it doesn't actually do anything. It doesn't lead to any obvious effects. But when that person then drinks alcohol, it can actually cause a severe reaction, and the person will feel nauseous and vomit. All right, so what I hope to have shown here is that interactions can occur whenever a patient takes more than one drug, right? Some interactions are intended and desired. So for example, the interaction between ampicillin and sulbactam is intended and desired. And the interaction between naloxone and morphine, naloxone is given in instances of drug overdose with morphine, but some of them are unintended and undesired. Right? So again, a person who's on warfarin, who may not have told the doctor that they're also on aspirin, may experience adverse effects, and that's not intended. Patients frequently take more than one drug, so we're going to look at different populations for the rest of the slides to look at which populations tend to take more than one drug, because and these include the elderly and women that are pregnant and other subpopulations, right? Because you might be taking multiple drugs to treat one disorder. So a disorder that requires most often multiple drugs are disorders such as hypertension or diabetes mellitus. You can have multiple disorders requiring different drugs. So someone who's got hypertension and diabetes and atherosclerosis may need an array of drugs to treat the various conditions. And then also we often forget that over-the-counter medications and some things that we actually take as part and parcel of our lifestyle, for example caffeine, nicotine, and alcohol, are actually considered drugs because they can interact with prescription medications that we're on. So this slide basically gives you an overview of the basic mechanisms of drug interactions. So this one basically tells you what the effect of drug interactions. This one tells you how it actually comes about. All right, so we're going to go from the top, make our way down the bottom. So the first one is direct chemical or physical interactions, right? So drugs can interact in a solution. Never combine drugs in one container unless there's no chance of a direct interaction. So when you combine two drugs and it changes colors or it comes out a solution, there's a precipitation, you know that perhaps you shouldn't give that drug. Sometimes what happens is the drugs interact at the site of at the cellular level. So an example for that, interactions at the same receptors, is the example that we used before with two drugs, morphine and naloxone, acting both on the mu opioid receptor. Morphine activates it, naloxone inhibits it. Sometimes what happens is, again, we're talking about interactions at the receptors, that it interacts at different receptors on the same tissue. So when we're looking at the effects of the autonomic nervous system on the heart, we know that the parasympathetic nervous system releases acetylcholine to act on the cholinergic receptors to actually slow down heart rate. And we've got norepinephrine and adrenaline. Epinephrine acting on the beta-1 adrenergic receptors, again on the heart, to actually speed it up. So you've got two different receptors on the same tissue working in opposite directions. Sometimes you have again a potentiative effect, so it's an additive effect. We think about diazepam and morphine. Diazepam is a benzodiazepine. Morphine is a mu opioid receptor, and what they do is both of them can cause depression of the central nervous system via different mechanisms, right? Diazepam through an influx of chloride ion into the cell to actually decrease the possibility of action potentials firing. Morphine through the inhibition of the respiratory centers in the CNS. So those are considered pharmacodynamic interactions. And then you've got interactions that are pharmacokinetic. So you think about pharmacokinetics. If you remember what pharmacokinetics, pharmaco refers to drugs. Kinetic is movement. So pharmacokinetics is the movement of drugs through the body. All right. And so the four different processes of pharmacokinetics is absorption, distribution, metabolism, and excretion. All right, so you can actually change each of those pharmacokinetic processes. So an example of altered absorption is the co-administration of epinephrine with a local anesthetic to actually lower the rate of absorption into the systemic nervous system. Or you have laxatives, which actually speed up the passage of food through the digestive tract, and so there's also a reduction in absorption, because as food moves quickly through the digestive tract, it's less able to be absorbed into the systemic circulation. Altered distribution. So altered distribution need to be combined with altered elimination to have significant or sustained increase in free drug levels. So what it's saying is that usually with altered distribution, it might be due to plasma proteins. And if you have 2 or more drugs that actually bind to plasma proteins, it might alter the levels of free drug. But what it's saying here is that in a healthy person, that really doesn't change very much in terms of the bioavailability and the distribution to the target tissue, except for when elimination is also altered. Altered metabolism. There are drugs that actually increase and other drugs that decrease the amount of hepatic enzymes that are able to metabolize drugs. And so you have drug A causing an increase in the enzymes. It means that drug XYZ is eliminated faster, is metabolized faster, and so the effects of drug XYZ decrease. On the other hand, we know that drug B decreases the hepatic metabolic enzymes, and so what happens is XYZ basically stay in the active form longer, and so the effects of XYZ is increase in terms of its duration. All right. Sometimes what happens is there are changes in the ability of the person to excrete drugs, and so that might be either due to changes in the glomerular filtration rate, possibly due to a decrease in cardiac output. So again, with shock or with hypertension, when you have a decrease in, or with heart failure, when you have a decrease in cardiac output, that will change the ability of the kidney to excrete drugs. Sometimes what happens is the amount of drugs that are reabsorbed also gets changed, and so that can be changed through ionization of the drug, either through manipulating the pH of the urine or by some other means. And then there's also the third process within the kidney, which is active tubular secretion, which is uses a transport system. And so the transport system can actually only transport so many a certain amount of drugs, and so if you have 2 or more drugs in the body, it has to actually decide which drug it wants to secrete and eliminate over the other ones. So again, these are, you can see here that you've got all the 4 processes of pharmacokinetics, and each of them can be altered by the interaction of 2 or more drugs. The other thing is that there are transmembrane transport proteins. So what you've got here is you've got a cell and you've got this transport protein, and the transport protein is called the P-glycoprotein. And what happens is the P-glycoprotein is involved in transporting drugs out of the cell. Right? So the arrow is out of the cell, and so if drugs actually go into the cell, what happens is this PGP transports drugs out. All right, and certain drugs can actually increase the amount of this PGP transport protein, and other drugs can inhibit the amount of PGP transport protein. And so what happens is if we actually look at increasing the amount of PGP transport proteins, right? So I'm going to draw a few more PGPs over here. If we've got more PGPs than normal, what happens is the amount of drugs that's absorbed is going to go down, right? And the amounts of drugs that actually go past the blood-brain barrier is going to go down, because as soon as it goes into the blood-brain barrier, it gets kicked out again into the out of the brain, and it can reduce the amount of drug entry in the fetal circulation by the same means, right? So as soon as drugs cross into the fetal circulation, what happens is this PGP is going to actually kick it out. And again, PGPs are also found in the kidneys, and so again it increases the amount of drugs that actually leave the peritubular capillaries and kicks them out into the tubules, right? So that's what happens when PGPs increase, are induced. When PGPs are decreased, the reverse is true. So when PGP is decreased, then absorption increases, drug entry into the CNS and fetal circulation increases, and elimination decreases. All right, so that's the story behind P-glycoprotein transmembrane transport protein system. The other thing is that some drug-drug interactions have toxicity to the same organs. And so the rule of thumb is that if you give 2 or more drugs, you have to check whether they have the potential to actually cause toxicity to the same organ. And if possible, we want to prevent interactions with 2 drugs that say are hepatotoxic. You don't want to give 2 drugs that are hepatotoxic because it increases the risk of the liver cells dying. Now, as well as drug-drug interactions, drugs can also interact with food. So what you see over here is that you've got changes in pharmacokinetics, right? And so let's look at them too. So what happens is when drug is taken with or without food, certain foods or any foods, what happens is the rate or the extent of absorption can change. So if the rate changes, say if you look at the first point, if you decrease the rate, what happens is it just delays the onset of effects. So if you remember, if you've got this drug response profile, right? So say this is the normal time, this is the plasma drug concentration in there. So this is normal. And then what happens is perhaps when food is taken, then absorption just slows. So it takes a little bit longer for the drug to actually get up to speed, and say minimum effective concentration is here, right? So instead of the drug starting to work at this time, what happens is when it gets taken with food, it takes a little bit longer for it to reach minimum effective concentration and to have a therapeutic effect. So that's an example over here. Sometimes what happens is the extent of absorption goes down. So if you look again at that slide, I'm going to remove this. So what happens when the extent of drug absorption is decreased is that you have a not that much drug gets absorbed. So again, what you have here is it might decrease the amount of drug being absorbed. So this is an example. So with milk and any calcium containing foods, if that's taken at the same time with tetracycline, it will actually decrease absorption. In some cases, food actually helps to absorb, right? Food actually helps to increase absorption. So an example is a high caloric meal with an HIV drug. So if you do this, what happens is the taking the drug together with high caloric meal will actually double the absorption, and so the absorption is doubled, right? And so that's a case where a drug-food interaction is actually beneficial. Okay, drug metabolism. One of the food that can actually affect drug metabolism is grapefruit juice. And what grapefruit juice does is it inhibits the intestinal enzymes that actually break down a few of the drugs that are commonly taken, right? So what happens is grapefruit juice inhibits intestinal enzymes. Now I'm going to put this intestinal, not hepatic, or not hepatic as much, because what this means is that if it only inhibits intestinal enzymes, it really only affects oral drugs, right? Because drugs that are given IV bypass the intestinal system, right? So this only affects oral drugs. But you look at how it actually affects it. So what happens is if a drug is given orally, it inhibits the enzymes, it can decrease metabolism, and so the plasma drug levels stay elevated. And we're talking about a huge increase in the plasma drug levels. So in the antihypertensive felodipine, it can be increased for up to 400%. Right? The effect of grapefruit juice, the other thing too, is that the effect of grapefruit juice can actually last 3 days. So supposing this is Monday, I have breakfast, I have grapefruit juice, and on Thursday I go to the doctor and the doctor prescribes me felodipine. So, and I don't even think about what I had 3 days ago, right? Because it's Thursday now, who knows what I had for lunch yesterday, let alone what I had for breakfast 3 days ago. And so I might actually forget to tell the doctor that I had grapefruit juice, or grapefruit, unless the doctor specifically asks, right? And so what happens is the felodipine, if it's being prescribed to me, might actually stay elevated in my system and might cause me to have hypotension. So again, that's not a very good interaction to have. A possibility is that drug can interact with food and cause toxicity. So a very good example of this is a monoamine oxidase inhibitors. What happens is that most of us will actually, who don't take monoamine oxidase inhibitor, what happens is tyramine is then broken down by monoamine oxidase. Right, so tyramine is broken down by monoamine oxidase. But if we are on monoamine oxidase inhibitor, what happens is tyramine is not inhibited by monoamine oxidase, right? And then what happens is it increases the release of norepinephrine. So norepinephrine release is increased, and it's very, very dangerous in terms of blood pressure, because the effect of norepinephrine on the blood vessels as well as on the heart, it can cause a hypertensive crisis. All right. Another example is spironolactone. Spironolactone is often referred to as a potassium-sparing diuretic, and it's one of the treatments to help with high blood pressure. And so what happens is people with high blood pressure may be told to actually decrease their salt intake, their sodium intake. And so what they do is they say, okay, sure, I'll decrease my sodium intake. I'm going to use salt substitutes instead. The problem with salt substitutes is a lot of them contain potassium chloride, right? Because the usual table salt we have is sodium chloride, and salt substitutes contain potassium chloride. And so what happens is spironolactone can lead to an increase in potassium levels, but so would taking salt substitutes. So taking in potassium chloride as salt substitutes can also increase potassium levels. And so what you have is you have an increase in the amount of potassium levels, and that might cause, potassium levels might increase to toxic levels. Another possibility for drug-food interactions is listed over here. So if you're on warfarin only inhibits the synthesis of those clotting factors which contain vitamin K. But if that person loves broccoli and cabbage, what happens, and that person eats a lot of broccoli and cabbage, is it can increase those very same clotting factors. So you've got a drug that works to try to decrease the possibility of clots occurring by decreasing the synthesis of clotting factors, and then you're eating broccoli and cabbage, which increases the synthesis of clotting factors. So it actually decreases the therapeutic effect of warfarin. And then another example is theophylline and caffeine. So caffeine, coffee, chocolate, tea, hot chocolate belong to the same group as theophylline, which is used in for treatment of asthma. And what happens is both components can lead to excitation in the central nervous system. So again, if you take too much theophylline and drink, 5, 6, 7, 8 cups of coffee, it might lead to an increase in CNS excitation. So the effects of drug, food, and drug-herb interactions, you can see over here. It can affect outcome of the therapy, can either increase or decrease outcome of therapy. And also just note that the risk of serious drug-food, drug-herb interactions is directionally proportionate to the number of drugs a patient is taking. So again, if you increase the number of drugs, you increase the risk of an interaction occurring. These drug interactions with other drugs, food, or herbs is very important when a person is taking drugs with a low therapeutic index. And remember, a low TI means that the difference between therapeutic and toxic is very, very low in terms of the dose. So it can be therapeutic at, say, between 10 to 15 micrograms, and then above 15 can be toxic. So it's got a very, very low therapeutic index. Just to make things difficult, many interactions are yet to be identified. So again, it's a lot of it comes down to vigilance on the part of the client, as well as on the part of the health professionals. Conventional drugs can also interact with herbal preparations, but again, there's not much information that are readily available in a reliable fashion. And then an example of a drug-herb interaction is St. John's wort, which induces drug metabolizing enzymes and basically causes an increase in the metabolic rate of some drugs. And so what happens is they're metabolized to an inactive compound, so it decreases the plasma levels and might lead to a decrease in therapeutic effect. Just some strategies to minimize drug interactions with other drugs, food, and herbs. Minimize the number of drugs a patient receives, very important. If possible, combine or cut out some drugs. Take a thorough drug, herb, food history. Be aware of illicit drug use. If metabolizing inducers are added or deleted, you need to adjust the dosage. And also maybe adjust the timing to minimize interference with absorption, especially when you've got drugs that are better tolerated on an empty stomach, right? That are better absorbed on an empty stomach. So an empty stomach means 1 hour before or 2 hours after. Or there are some drugs that need to be taken with food, especially drugs that might cause nausea. There are other drugs that cause an increase in gastric acid secretion. So again, we've got to watch out for that. And again, monitor the patient for early signs of toxicity. Again, patient education is also good, and be especially vigilant when a patient is taking a drug with a low TI. Now moving on, we're going to talk about adverse drug reactions. So this is the definition of an adverse drug reaction, and you can see here it can range from annoying or to life-threatening. Who's at risk? Very young, very old or older adults, ill, or people taking multiple drugs, right? So we also talked about how people taking multiple drugs will increase drug interactions. And then we're going to also talk about the very young and the older adults. People that are very ill, obviously there might be some compromise of certain organs, or even their ability to actually fight off infection and to cope with just life in general, as well as to cope with the number of drugs that are used to actually treat their illnesses. So again, these are just some stats that you've got over here, and then just note that most of these incidences were preventable. So just some definitions related to adverse drug reactions. So you've got side effects, you got toxicity, allergic reaction, and just note that very few drugs cause severe allergic reactions. Penicillins are the most common, and then you've got sulfonamides. There's some diseases that are called drug-induced disease or iatrogenic disease, and that means that it's kind of disease produced by a physician or a disease that's caused by a drug. So antipsychotics, some of them, can cause a decrease in dopamine levels, so much so that the patient can exhibit symptoms similar to Parkinson's. And then we talked about physical dependence. And then moving on, we've got a few other terms. So idiosyncratic effect is basically a drug response that's not common, and sometimes it's due to a genetic predisposition, right? Paradoxical effect is the effect that the person experiences is opposite to the intended drug effect. So for example, benzodiazepines causing excitement instead of sedation, which is more common in children and older adults. Sometimes what happens is drugs can cause cancer. So the irony is that some anti-cancer drugs can cause cancer, and the kind of cancer they cause may not actually pop up for another 10-20 years after the patient has been in remission. And so that's one of the big irony. And then you've got drugs that are teratogens and cause birth defects. So again, we're going to go through each of this as we go along here. So some drugs are toxic to specific organs. So you've got some examples over here, and note that you do not need to memorize the examples, right? You do not need to memorize these specific examples. What I want you to do is I want you to actually look at those examples and just be cognizant of it. And in some cases, you would have actually seen those examples in your clinical practice. Drugs can be hepatotoxic or can cause a change in the QT intervals. So let's go with hepatotoxic first. So hepatotoxic drugs can cause liver failure. So an example of that is acetaminophen. So acetaminophen can be metabolized down two pathways, and what happens is one of the pathways that acetaminophen is metabolized basically causes the production of metabolites that are toxic to the kidney, to the liver, sorry. And what happens is if that person has drunk a lot of alcohol, what happens is the liver enzymes are actually busy processing the alcohol, and so when the person takes acetaminophen because they wake up with a hangover and a headache, what happens is the acetaminophen is metabolized via this minor pathway, which causes the production of hepatotoxic metabolites, and that can cause liver damage, right? So just some checks to actually ensure that liver function is good is to watch out for jaundice, dark urine, light-colored stools, and all these kinds of symptoms. And then in terms of tests, to measure the levels of the enzymes AST and ALT, because they get increased with the possibility of liver damage. All right, so again, you've got monitoring there for the patient as well as when they come in to actually check liver function. So another group of drugs, what they do is they actually prolong the QT interval. So if you look at the normal ECG, the QT interval basically is this. So the QT interval is the time needed for the ventricles to actually relax, right? To repolarize after each concentration. And what happens is when the QT, instead of being this long, is actually that long, it might actually cause dysrhythmias, right? And it can cause a specific kind of dysrhythmias called torsade de pointes, which causes ventricular dysrhythmia, and then it can progress to VFib, which is fatal. All right, so just some strategies to actually monitor the patient is to minimize risk. So important not to use 2 drugs that can prolong the QT interval at the same time, and to monitor populations of people. So women, older adults, patients with low heart rate, congestive heart failure, congenital QT prolongation, low potassium and low magnesium. So you can see that it's quite a large proportion of an average population. So again, these are just some strategies to minimize risk of drugs that may cause liver failure and cause a prolongation of the QT intervals. Adverse drug reaction, sometimes they're easy to determine, they're easy to link back to a drug, but most of the time it's very difficult to determine whether a specific drug is responsible for a specific adverse effects, right? So again, that's why testing can come in. So you've got liver test, you've got tests for kidney, and then tests for bone marrow. So just some questions to ask in order to identify adverse drug reactions, and also just to note that half of new drugs, all new drugs that are out on the market, have serious ADRs that are not revealed during phase 2 and phase 3 trials. So if you remember, phase 2 and phase 3 trials are trials for people with the condition, but the problem with phase 2 and phase 3 trials, it can be done with people with populations of less than 1,000, and usually it can last only 1, 2, 3, 6, 12 months, right? And sometimes what happens is the adverse drug reaction is reported maybe after the person has taken it 3 years, or maybe after the person has taken it 18 months. Right? And the other thing is that if you've got a study that only has about 1,000 or even 3,000 people, and that drug only affects 0.1 of the population, what happens is 0.1 of 1,000 is one person. And they can say, okay, this one person suffered whatever, and it might just be an unusual event. It may not be linked to the drug, right? Whereas if a drug is on the market, it can be given to millions of people, and so 0.1% risk can actually translate to thousands, right? Tens of thousands of people. All right. So again, as a health professional, you need to be alert for unusual responses when given new drugs, and also once you suspect of a new drug causing a specific effect, it needs to be reported to Health Canada in Canada, or MedWatch in the US. So in order to minimize ADRs, everyone is responsible, right? The people that are involved in the whole sequence of the drug, from drug production to drug usage. So that includes the drug company, the person prescribing it, the person giving it, and then the person taking it, and their support system. So another thing is medication errors. So medication errors, as you can see here, is a major cause of morbidity and mortality. You've got some stats over here. Risk for error in hospitals is high because each medication order is processed by several people, and it also may be a highly intense and pressured situation. The nurse is the last line of defense in the sequence, so the nurse has a heavy responsibility to ensure patient safety. All right, there are different types of medication errors, but you can see here fatal medication errors. One of the big reasons is overdose, giving the wrong drug, or giving the wrong route. Right? 90% of all errors are due to human factors. So either human factors, communication mistakes, or drug name confusion. So communication mistakes may include things like not being able to read the prescriber's handwriting. Human factors may be knowledge, performance deficits, dosage, I should say miscalculation over here, so giving the wrong dose, right? So that's where the overdose actually comes in. So you've got a couple of different pairs of drugs that have a similar name, Lasix and Losec, quinine and quinidine. Medication errors have to be reported, and these reports are not meant to be punitive in nature. So just because you've they're not a firing offense, they're supposed to be a learning situation. So these are just some ways to actually prevent medication errors, involvement of the family and the patients, creating an atmosphere that's dedicated to safety, giving tools and information, instituting checklists for high alert drugs. Note over here, 20 drugs are responsible for causing 80% of the med error related deaths. Replacing handwritten med orders with computerized system, having a senior clinical pharmacies according physicians on round so they understand what's required, barcode system, not using error-prone abbreviations, and performing medication reconciliation. So again, that medication errors are not meant to be punitive in nature when they're reported. So over here, what we're moving to is we're moving to individual variation in drug responses. So some differences in patient response may be due to body weight and composition. So body weight, very self-explanatory, but body composition is the distribution, it's a proportion of water to lean muscle to fat. Might actually affect the different parameters, pharmacokinetic parameters of the drug as it goes through the body. Age can be significant, especially with the very young and very old, so we're going to look at that later. Pathophysiology, especially kidney and liver disease, may so kidney reduces excretion, and so the drugs can stay there for longer, increasing toxicity. Liver, it reduces metabolism, right? Liver disease reduces metabolism, so the drugs can again stay there for longer and increase the risk of toxicity. Changes in acid base might also alter the 4 different pharmacokinetic processes. And then electrolyte status, it's rare for it to have a significant impact on drug responses, but there is that possibility there. We've also got tolerance, right? So tolerance, you've got it over here, decreased responsiveness to a drug as a result of repeated drug administration, such that higher doses are required to get the same therapeutic effect. So you can have a pharmacodynamic tolerance, so that will change the number of receptors that are present on the target cell. Okay, you can have metabolic tolerance, in which case the hepatic enzymes are increased, and so it's metabolized faster, and so you need more drug to actually have the same effect. And then you've got another one which is called tachyphylaxis, which is a reduction in the drug responsiveness when the drug is given repeatedly over a short period of time. You've also got placebo effect, when you've got a drug that's given that really has no effect, no intrinsic activity on its own, and it's all in the thought processes. You can have changes in absorption, right? Changes in absorption really to do with oral drugs, and that can lead to changes in bioavailability. And so you've got different things that affect bioavailability. So pH, gastric pH, diarrhea, constipation will actually affect the amount of time that the drug basically stays in the digestive tract, and will affect absorption. And food in the stomach may also absorb rate or extent of absorption. Okay, and then you've got different coatings on drugs. So you've got liquid versus tablets, you've got enteric coating, you've got sustained release formulations to actually alter the absorption rate of the drugs. Some of us have got unique variations in our genes, which then will affect the person's response to drugs. So it can either affect drug metabolism, either increase or decrease the drug metabolism, and that will actually change the amount of time the drug stays in the system. You can also change the amount of receptors that are found on the target cells, and that will actually affect how the drug actually responds to it. Gender also has a role to play. So alcohol is metabolized more slowly by women. Some analgesics are more effective in women, and then quinidine causes greater QT prolongation in women, right? So again, the differences between men and women. Race, ethnic origin, really it gets linked back to pharmacogenetics. Morbidities. So again, if you have multiple pathologies, it requires multiple drugs, and it will increase the amount of drug interactions. Remember, the number of drugs is directly proportional to the risk of drug-drug interactions. Diet. So if a person is starving, isn't taking enough protein, it can cause a decrease in the protein synthesis, especially albumin. And you can also diet in terms of if a person is on monoamine oxidase inhibitor and eats tartamine containing foods, that can also cause a variation. This is very, very important. Failure to take medication as prescribed, and sometimes it's unintentional, right? So manual dexterity, so the ability to open a bottle. So the child-proof bottles also can be very hard for older adults to actually open up, right? The ability to read well small print, right? If you can't tell the difference between a 1 and a 7, that might cause problems when you're actually supposed to be taking 1 pill and the person takes 7, right? Intellectual capacity, psychological state, attitude towards drugs. Do you need the drugs? Do you think you need the drugs? No, I don't need it, right? Because I've taken it for 4 years. I think my hypertension is cured. And then lastly, cost, ability to pay for medication, right? And then individual variation in drug responses are again drug-drug interactions, which can be linked to multiple morbidities. All right, so moving on, drugs during pregnancy and breastfeeding. So again, one of the big things is that no pregnant woman really wants to be a guinea pig to test drugs that could potentially be harmful to their fetus or infant as they're pregnant or breastfeeding, right? And 2/3 of pregnant patients take at least one medication. Most take more. So some common medications that are taken during pregnancies are medications that are related to pregnancy problems, right? If a person has a chronic disorder, they need to actually keep up with a medication regime. Someone with an infectious disease, or a pregnant person who's got cancer. And then you've also got people that are continuing to take drugs of abuse because maybe they can't stop even when they're pregnant. There are some changes that occur during pregnancy. So renal blood flow is doubled and renal excretion is accelerated. So again, if renal blood flow is doubled, you need it excretes drugs much faster, so you need increased dose, right? But at the same time, the tone and mobility of the bowel decreases. So what happens is the drug basically stays in the digestive tract, so it increases the rate of absorption and the extent of absorption. So that prolongs drug effects. So again, it's you have to weigh up all the different drugs that a pregnant person is taking to actually try to figure out what's going on, and you can adjust the doses accordingly. Now, all drugs can cross the placenta to varying extent. So obviously lipophilic drugs can cross the placenta much more easier than hydrophilic drugs, right? And then some adverse effects during pregnancy. Not only can it affect the mom, but it can also affect the developing fetus. So these are just some unique effects that don't really affect a person if they're not a developing fetus or if they're not pregnant. Now, some drugs can cause birth defects. But having said that, it should be noted that less than 1% of all birth defects can be directly linked to drugs, right? But there are some drugs that cause some birth defects. Identification of teratogens is very difficult, and the reason being, if you look down below, is that really the critical period is weeks 3 to 8, because that's when organs and limbs and various facets of the human body are being formed. And so if a woman ingests drugs that cause these malformations, it can actually cause these birth defects. The other thing is a person may not know that they're pregnant between weeks 3 to 8, right? So it's really, really hard to actually monitor or to cut back or to modify your lifestyle if you're not really aware that you're pregnant, right? And then the fetal period is anywhere from week 9 through to delivery. And what happens is those organs are formed already, but what happens is teratogens can cause functional impairment. So the functional impairment can be either neurobehavioral deficits or metabolic deficits, right? So again, minimize risk for teratogens. So some teratogens, or minimize the risk for drug use. And again, it's very difficult because as I said, no woman wants to be a guinea pig for testing drugs that are potentially teratogenic, and there's a lack of good, solid, reliable, decent evidence in animals, right? Some drugs cause immediate defects, so thalidomide with limb malformation of the limbs, and some defects occur over time, so with alcohol. So again, it's very, very hard to monitor which drug actually cause specific teratogenic effects. During breastfeeding, what happens is there are drugs can be excreted in breast milk, and so it can actually get into the infant. So ways to decrease risk to the infant include taking drugs immediately after breastfeeding, avoiding drugs that have a long half-life, and again, very important to avoid this because if it has a long half-life, the chances of it actually getting into the breast milk increases. Right? Choose drugs that tend to be excluded from milk. So again, if you reduce the amount of drugs that tend to be transferred over to the breast milk, then it reduces the ability for it to actually get into and affect the infant, right? And avoid drugs that are known to be hazardous. So again, I've got a picture over here just to basically give you the overview of the embryonic period as opposed to the fetal period, and then you've got all the different congenital defects that are associated with it. So you can see over here, after week 8, you can see that some of the effects are actually functional effects. Now we go on to pediatric patients. So a pediatric patient is referred to as a patient younger than 16 years of age, and these are the various classifications of the patients as they go through the lifespan. All right, some challenges: ongoing growth and development. Different age groups have different challenges, and we're going to look at that. And 2/3 of drugs used in pediatrics have never been tested in pediatric patients in a controlled clinical setting. So again, why would you offer your 6-year-old, or 10-year-old, or 2-year-old as a subject in a clinical trial that has the potential for causing a lot of different effects that you don't know because it's an experimental drug, right? So again, lack of evidence means that some of the effects haven't been tested. Pediatric patients respond differently to drugs than the rest of the population, and I want to skip down to the second point, right? So you see over here, 20% of drugs are not effective in children, even though they're effective in adults. 30% of drugs can cause unanticipated side effects, some of which are potentially lethal, and 20% of drugs require dosages that are different from those extrapolated from adult doses. And we'll look at drug extrapolation a little bit later on. But basically, what can happen is you can say, okay, I've got a 100-pound 10-year-old, and the average dose for an adult is maybe 500 milligrams. So for a child, I'm going to extrapolate down and say it's 250, right? But again, that may not work because the child works differently than the adult. All right, so again, they respond differently because some of the organs can be immature. Kids grow at different rates, and you can see this when you look at line up a bunch of grade 5s. You can have some grade 5 girls reaching pretty much adult height, and some grade 5 boys being really small and short, right? And there's if they show greater individual variation, there's an increased risk for adverse drug reaction. So I want to show you just the differences in response between an adult and an infant. And so this is the amount of drug in the blood. This is as time goes on. So what we have here is we have two routes of administration, IV injection and you have sub-Q injection. And so what you see here is this is the normal profile. So IV injection, there's a lot of drug being injected into the systemic circulation, and then you've got metabolism and excretion happening over time. In an infant, you can see here that metabolism and excretion occurs at a much slower rate. So what happens is in the infant, the drug is therapeutic for this long, whereas in or above mean effective concentration for that long, whereas for an adult, the drug is only above mean effective concentration for this long. Right? So again, for an infant, you want to give the drug less frequently because it hangs around in the plasma much longer. With a sub-Q injection, you can see over here that the amount of drug that's absorbed in the infant is much bigger, right? Much more complete. And again, because of the immaturity of the kidney and liver, the processes of metabolism and elimination basically slow down the rate of disappearance of the drug from the infant. So again, in an adult, it stays above mean effective concentration for that long, whereas in a child or in an infant, it stays for this long, right? So again, drug doses and drug administration need to be adjusted accordingly. In neonates and infants, so remember infants is 12 months and less, what happens is you need to actually figure out whether or not a drug can reach its site of action and how quickly it does that. And then you need to determine the intensity or duration of the drug response. So we're going to look at the immaturity of the infant with the 4 pharmacokinetic processes. So in terms of dosage determination, most commonly based on body surface area, and really initial pediatric dose, if there's not a standard dose for infants and neonates and kids, it needs to be based really on body surface area. I'm not expecting you to memorize this, right? I'm not expecting you to memorize this, but just to know that it's based on body surface area rather than the age of the child or the weight of the child or the height of the child, right? So body surface area is the most accurate, but again, it's only an approximation. So the 4 pharmacokinetic processes, so you can see here in terms of oral administration, gastric emptying is prolonged, so it takes a long time for a breast milk or formula milk to be in the stomach, and it's very irregular until about 6 to 8 months. Gastric acidity is very low, so it means that for drugs that are ionized, it can actually affect absorption, right? In terms of intramuscular administration, it's slow and erratic a few days after birth, and then it's more rapid than neonates and adults during early infancy. So it's very slow, and then it speeds up during early infancy, and then it slows down after that. Transdermal, so a patch application or a topical administration is more rapid and complete because they have very thin skin and they have greater blood flow to the skin. So it basically is absorbed a lot more. And so infants are at increased risk of toxicity from topical drugs. In terms of drug distribution, liver is immature, and so what happens is protein binding is limited. right? So reduced doses is needed. Adult levels are reached by 10 to 12 months. Blood-brain barrier isn't fully developed, and so what happens is the blood-brain barrier is leaky. Things that would otherwise not go into the blood, into the brain, may go into the brain at higher concentrations. So again, need to reduce doses of CNS active drug. Hepatic metabolisms is very low in newborns, so newborns are very sensitive to drugs that are metabolized by the liver, so you need to reduce the doses. And then within a month it increases and is mature at about 1 year, right? Renal drug excretion, again, the kidneys are not mature at birth, and so it needs to actually be given in reduced doses or with prolonged dosing intervals up until the infant is about 1 year. When the child is 1 year or older, the pharmacokinetic parameters that are listed there, distribution, absorption, metabolism, excretion, very similar to adults, with the exception of the liver. So children in this age group metabolize drug faster than adults. So their liver is fully functional and even more than fully functional. And so if you've got a child that's maybe 18 months old, they might actually process drugs much more quicker, and so you need to give higher doses, and then it slowly declines in terms of the drug, in terms of the enzyme levels after 2, declines at puberty, and then it reaches adult levels after that. So again, you need to increase dose or to decrease interval. So instead of every 6 hours, it might need to be every 4 hours, right? So that's what you do. Adverse drug reactions and compliance. So children are vulnerable to unique adverse effects because they are growing. So these are just some examples. And again, you don't need to memorize these examples. And so in order to actually promote compliance or adherence, you need to actually do a combination, one or some of these things, right? To actually go through the dose size and dose timing, the route and technique of administration, duration of treatment, with a technique demonstration. I'm thinking about using a puffer or an inhaler, or an EpiPen or something, right? That needs demonstrating. You practice it, go through it with the child. The child needs to know where to store the drug, the child and the parent, and then again just education of the parent and the child and the guardian and the support system, so that you know what the desired response is and to be cognizant of potential adverse effects. Other end of the spectrum, older adult patients. So again, disproportionately high prescription use exists in the older adult population, and we know that if you increase the number of drugs that a person takes, you increase the risk of ADRs, right? So you've got here more adverse drug reactions and more drug-drug interactions, as well as older people tending to take more drugs is because you've got altered pharmacokinetics. So basically the liver and the kidney, in terms of blood flow and the mass, the size of the kidney, the size of the liver, is declines in older adults. They tend to have multiple illnesses and illnesses that are more severe than, say, would affect a younger adult. And also poor compliance, right? So again, pharmacological intervention in older adults, because of all these, you need individualization of treatments, need close monitoring of therapeutic and toxic effects. You need to ensure that the drug regimen is being stuck to. So again, checking in with support systems and what have you. And again, the goals of the treatment is not necessarily to treat the condition, but to reduce the symptoms in order for their quality of life to be improved. Pharmacokinetics in older adults, you can see here the 4 processes over here. So again, percentage of oral dose that's absorbed does not change with age, but rate of absorption may change. So either because the stomach's not working as well as it has in the younger adult, or there is a reduction in blood flow to the digestive tract. So splanchnic artery carries blood to the digestive tract. And then you've got changes in body fat, changes in water, changes in lean protein, changes in lean muscle mass, and changes in protein synthesis, especially due to starvation or malnourishment. And so that might affect the distribution of the drug throughout the body, right? Liver function declines with age. And so if it declines with age, what happens is the drug might actually stay in the body for a lot longer. So half-life might increase, and you might have prolonged response or more intense response because it stays higher for longer, right? The other thing too is drugs that have high first-pass effect. The first-pass effects presumes that the liver is healthy, and so if the liver mass and blood flow is reduced, then the first pass effects goes down, and so more drug actually ends up in the systemic circulation. So that's how you get more intense responses. Renal function declines with age, and so what happens is, again, half-life increases because the drug stays in the body much longer, right? So that's one thing. So assessment of renal function, again, renal creatinine clearance rather than serum creatinine. Creatinine clearance is the active work of the kidney in clearing creatinine, where serum creatinine is a one time point value, and so you've got to actually measure creatinine clearance. So pharmacodynamic changes in older adults. So this pharmacodynamics is what the drug does to the body. And so we're looking at basically what happens to the receptors, right? So some drugs have more intense effect in older adults. Some drugs have less intense effect in older adults, right? And part of it is due to receptors, right? Either there are less receptors. So you've got receptors over here. So that's in a normal person. So either an older adult might have less of these receptors, right? Or what happens is the drug that binds to the receptor has less affinity, so it doesn't want to bind as well to the receptor, right? So it has less affinity. Or you can have the opposite. So you can have so if you have less receptors, then it's less effective. If you have more receptors and greater affinity, then it's more effective. Adverse drug reactions in the older adults, you can see over here, symptoms in older adults are non-specific, so it's very hard to actually link it back to the drug that they take, right? But it's 7 times more likely. It's responsible for 16% of hospital admissions and 50% of medication-related deaths. So some factors that increase the risk of adverse drug reaction is the drugs accumulate because the kidneys aren't working. The drugs accumulate because the kidneys aren't working, right? And then you've got polypharmacy, taking multiple drugs and taking drugs that have low therapeutic index, so they have a higher chance of toxicity. You have illnesses, lots of illnesses, multiple pathologies, and then the illnesses tend to be more severe. And then you've got individual variations, right? Secondary to altered pharmacokinetics, so altered absorption, distribution, elimination, metabolism. And then also you have poor patient adherence. Either they can't see, they can't open the bottles, they have cognitive impairments, or the drug regimen is so complex they can't actually keep up with it, right? And so you need adequate supervision of long-term therapy to make sure that they actually adhere to it, because they might actually say it's too expensive, I'm going to cut out on this drug this month because it's too expensive. So measures to reduce ADRs, thorough drug history, consider changes due to age, monitor response, and taking plasma drug levels for those drugs with a low therapeutic index, monitor for drug-drug interaction, Keep the regimen simple. So again, maybe using combination drugs, or making sure that the patient only needs to take drugs during meal times, not when they get up, not 5 times a day. So restricted to maybe 2 times a day, twice a day, so that it increases patient compliance, and to avoid drugs that are on the Beers list. The Beers list is drugs that have a higher rate of toxicity for older patients. And then encourage patients to dispose of old medications because they don't work as effectively, and they might be tempted, if the old medications are around, to actually not purchase new medications that are effective. And then the last slide, promoting compliance in older adults. So some of the non-compliance is intentional. So it can be due to high cost of drug, or the dose is too high, so it increases the risk of side effects. Or the patient can say, I've been taking this drug for 10 years, surely it's time for me to stop. And then you've got the lack of manual dexterity as well. Sometimes it's unintentional, right? Sometimes it's unintentional. Either a person forgets, or it costs a lot and they can't really get to the pharmacy. They can't afford the price of a bus ticket or a taxi cab to go to the pharmacy. Sometimes they need to take drugs 6 times a day instead of just twice. And sometimes they're not quite sure how to actually take the drug, right? If you've got 3 liquids and one has to be given, I don't know, when the nurse comes, home health nurse comes, and the person actually drinks it by mistake, that's a valid thing, right? Because if they've got one liquid that needs to be taken orally and the other 2 may be injected, then they might just forget what's what. So again, to increase compliance, need to simplify drug regimens, need to have clearly labeled and easy to open containers. As I said, some containers that are child proof are also older adult proof. You need to have an appropriate dosage form, and also daily reminders, support system, frequent monitoring. All right, so I've taken a little bit longer than I thought, but it's all in one, so I hope you can go through it and not have any surprises with this lecture.